Welcome to this Step 2 clinical knowledge review on chronic eye conditions and test-taking strategies. This video is brought to you by Roadmap to Residency. Today we are going to break down the most common question patterns you will see on your board exam for cataracts, glaucoma, diabetic retinopathy, macular degeneration, and refractive errors. The goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies so you can pick the right answer quickly and confidently. Make sure you have reviewed the ophthalmology sections of first aid and your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn to recognize the classic question stems for chronic eye conditions. These come up frequently on board exams. Second, we will apply specific test-taking strategies for cataracts, glaucoma, diabetic retinopathy, and macular degeneration. Third, we will master the next best step question format for managing these conditions and understanding refractive errors. Remember, this video assumes you have already reviewed the ophthalmology and neurology chapters in first aid and your question bank. We are here to help you apply that knowledge on test day, not replace it. The first strategy is understanding the painless versus painful vision loss split. This is one of the most important frameworks for eye questions on the boards. When you see gradual, painless vision loss in an older patient, your differential should include cataracts, open-angle glaucoma, and age-related macular degeneration. The key differentiator is what type of vision is affected. Cataracts cause overall blurry vision with glare. Open-angle glaucoma causes peripheral field loss first. Macular degeneration causes central vision loss. On the other hand, when you see sudden painful vision loss with a red eye, think acute angle closure glaucoma. This is the emergency presentation the boards love to test. Look for the classic triad of eye pain, halos around lights, and a mid-dilated pupil that does not react to light. The second strategy focuses on recognizing diabetic eye disease progression. This is heavily tested because the boards want to make sure you understand the staging. Non-proliferative diabetic retinopathy is the early stage. The hallmark findings are microaneurysms, which appear as tiny red dots on fundoscopy. You will also see dot and blot hemorrhages, hard exudates, which are yellow waxy deposits, and cotton wool spots, which represent nerve fiber layer infarcts. The key board pearl here is that microaneurysms are the earliest clinical finding. Proliferative diabetic retinopathy is the advanced stage and the one that demands urgent action. The defining feature is neovascularization, meaning new blood vessels are growing where they should not be. These fragile new vessels can bleed into the vitreous or cause tractional retinal detachment. The boards want you to know that proliferative disease requires referral for laser photocoagulation or anti-vascular endothelial growth factor injections. Do not miss this escalation. Now let us talk about high-yield stem recognition. For cataracts, the classic stem describes an elderly patient with gradual blurry vision, trouble driving at night, increased glare sensitivity, and colors appearing faded or washed out. The key test-taking point is that cataracts cause a progressive, painless decline in vision that eventually interferes with daily activities. Surgery is the definitive treatment, but only when the patient is functionally impaired. For glaucoma, the boards love to distinguish between open angle and angle closure. Open angle glaucoma is the chronic, painless version. The stem will describe slow peripheral vision loss with elevated intraocular pressure and optic disc cupping. Angle closure is the emergency. Look for sudden onset of severe eye pain, halos around lights, nausea, and a mid-dilated pupil that does not react. For macular degeneration, the stem focuses on central vision loss in an elderly patient. The dry form is more common and shows drusen, which are yellow deposits under the retina. The wet form is more severe and presents with sudden visual distortion. Amsler grid testing showing wavy lines is a classic board clue for wet macular degeneration. Let us walk through this practice question together. We have a 72-year-old woman with a 2-year history of progressive difficulty driving at night, increased glare from headlights, and washed-out colors. Her visual acuity is 20/80 in both eyes, and slit lamp exam shows lens opacification bilaterally. Before I reveal the answer, let us think about this the way you should on exam day. What are the buzzwords here? Progressive vision loss, glare, night driving difficulty, faded colors, and lens opacification. This is a textbook cataract presentation. Now look at the answer choices and think about which ones you can eliminate right away. Here is how to walk through this answer. Step 1. Spot the pattern. The buzzwords are all there. Elderly patient, progressive blurry vision, difficulty with night driving, increased glare, washed out colors, and the slit lamp showing lens opacification. This is a classic cataract stem. Step 2. Apply the Board rule. The key rule for cataracts is that surgery is indicated when vision loss interferes with daily activities. This patient has a visual acuity of 20/80 and cannot drive safely at night. That meets the threshold for surgical referral. Step 3. Eliminate wrong answers. Choice A, corrective lenses, might help in early cataracts but cannot fix lens opacification at this stage. Choice C, topical corticosteroids, is a trap answer because steroids actually cause cataracts, they do not treat them. Choice D, observation, is wrong because the patient is functionally impaired. The correct answer is B, referral for cataract surgery. Now let us try another question. A 65-year-old woman comes to the emergency department with sudden severe right eye pain, blurred vision, and halos around lights. She is also nauseated and vomiting. On exam, the right eye is red, the cornea is hazy, and the pupil is mid-dilated and non-reactive. Take a moment to think about this. What diagnosis jumps out at you? What are the key buzzwords? Sudden onset, severe eye pain, halos, nausea, red eye, hazy cornea, and a mid-dilated fixed pupil. This is a classic acute angle closure glaucoma presentation. Now the question asks about initial treatment. Think about what you need to do first in this emergency. Let us walk through this answer. Read the question carefully. The STEM is a textbook acute angle closure glaucoma presentation. Every buzzword is there. Sudden severe eye pain, halos around lights, nausea and vomiting, red eye, hazy cornea, and a mid-dilated pupil that does not react to light. This is an ophthalmic emergency. Now here is the critical test-taking point. The question asks for initial treatment. The definitive treatment for angle closure glaucoma is laser peripheral iridotomy, but that is not the initial step. You need to lower the intraocular pressure first with medical therapy before any procedure. The correct answer is B, topical timolol and pilocarpine. Timolol is a beta blocker that reduces aqueous humor production. Pilocarpine is a miotic that constricts the pupil and opens the drainage angle. Together, they rapidly lower intraocular pressure. Choice A, corticosteroids, does not address the acute pressure elevation. Choice C, acetazolamide alone, is part of the regimen but incomplete without topical agents. Choice D, immediate surgical iridotomy, is the definitive treatment but not the initial step. The boards love testing this distinction between initial and definitive management. Now let us cover diabetic retinopathy management for the boards. This is a heavily tested topic. For screening and prevention, remember that all diabetic patients need annual dilated fundoscopic exams. The timing depends on the type of diabetes. Type 1 diabetics should begin screening 5 years after diagnosis because retinopathy rarely develops before that point. Type 2 diabetics should begin screening at the time of diagnosis because they may have had undiagnosed diabetes for years. The most important thing you can do to slow retinopathy progression is tight glycemic and blood pressure control. For treatment by stage, mild non-proliferative disease is managed conservatively with observation and continued glycemic control. Severe non-proliferative and proliferative disease require more aggressive intervention with laser photocoagulation. For diabetic macular edema, anti-vascular endothelial growth factor injections are the first-line treatment. The boards love testing when to escalate from observation to intervention, so make sure you understand the staging. Here is our third practice question. A 55-year-old man with type 2 diabetes for 15 years comes in for his annual eye exam. His hemoglobin A1C is 9%, meaning his blood sugar is not well controlled. On fundoscopy, you see microaneurysms, dot and blot hemorrhages, and new blood vessel growth on the optic disc. Think about what those findings tell you. Microaneurysms and hemorrhages are features of non-proliferative disease, but new blood vessel growth on the optic disc is the hallmark of proliferative disease. That is the critical finding here. What does proliferative disease require? Think about the management algorithm before looking at the answer choices. Let us break this answer down. Step 1. Spot the classic pattern. The patient has microaneurysms and dot and blot hemorrhages, which tell you there is diabetic retinopathy. But the critical finding is the new blood vessel growth on the optic disc. That is neovascularization, and it means this patient has proliferative diabetic retinopathy. Step 2. Know the key distinction. Once you see neovascularization, you have crossed the threshold from non-proliferative to proliferative disease. This changes the management entirely. You cannot just observe. Choice A, continuing observation, is only appropriate for mild non-proliferative disease. This patient has progressed beyond that. Choice C, anti-vascular endothelial growth factor injection, is the first-line treatment for diabetic macular edema specifically, but the question does not describe macular edema. It describes proliferative disease with neovascularization. Choice D, tightening glycemic control alone, is always important but insufficient once proliferative changes have developed. You need definitive treatment. The correct answer is B, panretinal laser photocoagulation. This is the standard of care for proliferative diabetic retinopathy. Here is an important test-taking pearl that covers refractive errors and macular degeneration. For refractive errors, the boards like to test whether you know which lens corrects which problem. Myopia or nearsightedness means the patient can see near objects clearly, but distant objects are blurry. This is corrected with concave or diverging lenses. Hyperopia or farsightedness is the opposite. The patient sees distant objects better than near objects. This is corrected with convex or converging lenses. Presbyopia is the age-related loss of near vision accommodation that typically starts after age 40. Astigmatism causes blurry vision at all distances because the cornea is irregularly curved. For macular degeneration, the most important distinction is dry versus wet. Dry macular degeneration is far more common, about 90% of cases, and progresses slowly. The hallmark finding is drusen, which are yellow deposits under the retina. Wet macular degeneration is less common but more severe. It causes sudden vision distortion from choroidal neovascularization, meaning abnormal blood vessels grow under the retina. The treatment for wet macular degeneration is anti-vascular endothelial growth factor injections. The Amsler grid test is a classic board question clue. When the patient sees wavy or distorted lines on the grid, think wet macular degeneration. That wraps up our review of chronic eye conditions test-taking strategies for Step 2. Let us do a quick recap. Remember the painless versus painful vision loss framework. Cataracts, open-angle glaucoma, and macular degeneration are painless and gradual. Acute angle closure glaucoma is painful and sudden. For diabetic retinopathy, know the staging from non-proliferative to proliferative and when to escalate treatment. For refractive errors, remember which lens corrects which problem. And for macular degeneration, know the dry versus wet distinction, and that wet disease gets anti-vascular endothelial growth factor therapy. Review the ophthalmology sections of First Aid and your question bank for the foundational content. If you found this video helpful, please like and subscribe to our channel for more board review content. And if you want personalized tutoring or residency advising, visit roadmap2residency.com to connect with our expert tutors and residency advisors. Good luck on your exam, you have got this.